I recognize the Vice Chair of the subcommittee,
Thank you.
Ms. Harshbarger.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. I'm excited about this line of questions, and I hope you are too. I'll start with Mr. Parker. You know, I'm excited about the fact you've got a one-stop shop for telehealth, basically telemedicine. If you can do the labs, the prescription, give them the price and do all that and bill insurance or let them do a cash model, kind of like a concierge service, you know, when you walk into a brick and mortar. I guess enhancing the role of the clinician is a key win for technology. And as part of the expansion of the over-the-counter drug class, the FDA promoted something called additional conditions for non-prescription use. And what this essentially means is consumers can answer some questions on a phone app or another technology platform to determine if a drug is right for them and then access a prescription drug therapy. So how do you see technology and automation as a platform to expand and reinvigorate the practice of community pharmacy, since that's what I am, a compounding pharmacist, and I have a community pharmacy?
Yeah, it's a great question, and I think, as we all acknowledge, pharmacists are underutilized compared to their
Absolutely.
capacity. And I do think if you take some of the work that we've done at General Medicine, where we've worked really hard to codify these intakes for specific medications, so it's very, the clinician, which in this case could be a pharmacist, has all the information they need to make a judgment on whether it's appropriate for the patient in that moment, would apply very well in that setting. I think wouldn't just be constrained to a traditional clinical setting. And so I think a lot of the logic, infrastructure, and work we're doing would be a great opportunity for pharmacists to participate more in that.
Absolutely. Thank you for that. We need to practice at the top of our license, which is something I'm working on too. Mr. Toy, you mentioned that as far as utilizing your community provider in rural areas and your pharmacists. What do you think about this?
Absolutely. I think that, and you probably see this in your own practice, but there's not a lot of coordination right now between the actual pharmacist and the physician. Oftentimes the physician uses their mind, they think about things, they write a script, and then they're like, okay, where would you like that filled, right? Yeah. That's the question they ask the patient. And so what we want to make sure is that there's coordination there and make it very easy for the pharmacist to have the same information that was available. And the thing that AI can do also is take that same information and customize it, not just to the patient, but customize it to the clinician in question. So it'll show a certain version of that to the PCP, and it'll show a more pharmacist-relevant version of that to the pharmacist. But they're seeing the same data, but two different facets of that same data, so they can then apply their clinical
Well, you
training.
work with collaborative agreements between the physician and the pharmacist is how you would do that, and every state's different. So, you know, that's why I'm looking at an ECAPS bill and some other things associated with that. So, yes, sir, I got it. I'm glad you're on my team. Thank you.
Absolutely.
Dr. Ibrahim, while some applications of AI in healthcare, such as basic chatbot, may appear relatively low risk, others carry higher stakes, including tools targeting mental health, minors, or care and coverage of determinations. Should Congress begin to define high-risk categories of generative AI in healthcare? And if so, what safeguards such as independent validation of clinical claims or patient safety protocols for sensitive use cases, maybe labeling and disclosures for consumers, and what would best protect that patient without stifling that innovation?
Thank you, Congresswoman. Innovation moves at the speed of trust. That is something we've all sort of been trained and brought up in. In our practice, anything that we've tried to bring to patients requires a partnership with hospitals first, where we map out what do we have the capabilities to do, what are their needs. We pilot things several times in historic data before even trying it in real clinical practice, and then have rigorous milestones to meet before it actually gets scaled to any other settings. And that's been our practice, in part because that is necessary for our business. If we do not establish that trust and maintain it, we will lose our clients. So it's required for us to do that fundamentally. The FDA has some precedent for devices, which is what much of this has been mirrored on. And there likely is a similar tiering of class 1, 2, 3 devices that would mirror an AI technology. I think that would be welcome guidance to help create some roadmaps so we understand where we need to spend a lot of time and be methodical and rigorous, and where are things that we can accelerate faster.
Yeah, output's only as good as the input, and it better be correct, right? Okay, thank you, sir. And, Mr. Chairman, I yield back.
Gentlelady